All right. Well, welcome to the endocrine imaging session. We might get underway now.
So it's with pleasure that I introduce our next speaker, Dr. Barry Shulkin. He is Chief of Nuclear Medicine at St. Jude's Children's Hospital in Memphis, Tennessee. He's previously been at University of Michigan, and his research interests include MIBG uptake in neuroendocrine tumors and molecular imaging of pediatric tumors. And his talk is entitled Functional Imaging of Adrenal Tumors.
Thank you, Crockett. Throughout this presentation, you'll see a few letters crossed out. I'm on a crusade against unnecessary letters. The objective of this talk, then, is to review various functional imaging agents that have been used to examine tumors of or related to the adrenal gland and identify the role of functional imaging agents in the management of selected disorders of the adrenal gland. A couple of disclosures. I have nothing even remotely interesting to disclose. A couple of disclaimers have to do with the terms AC and NAC. Usually those are conceived of as attenuation corrected and non-attenuation corrected. For the remainder of this presentation, they will refer to as authoritative and comprehensive. NAC, then, neither authoritative nor comprehensive. The remainder of this lecture will be characterized by anecdotes, unpublished observations, and hearsay. One thing I've learned throughout my career is reader, listener beware. The weaker the data, the stronger the opinions. The fewer the facts, the louder the rhetoric. Our hospital is situated in Memphis, Tennessee. Tennessee is a state in the south central United States. Here's a blow up of Tennessee. Memphis is in the far southwest corner, bordering Arkansas and nearly Mississippi. We have a tri-state region. One of the borders of the state is the Mississippi River, of which we are very proud. Biggest river in the U.S. A few months ago, well, actually about a month ago, there was a lot of rain up north in the drainage basin. Here you can see the trees which lie on in front of the running track that's usually available. All right, back to the adrenal glands. They are two functionally distinct endocrine glands in a single capsule. Roughly pyramidal structure, 2 to 3 centimeters wide, 4 to 6 centimeters long, and about 1 centimeter thick. Only 4 grams of a normal weight, 90% cortex, 10% of medulla. It's really amazing functionally that we are able to image such a small component of a small gland using functional imaging agents. The cortex and the medulla, the cortex composed of the glomerulosa fasciculata and reticularis. Imaging may be used to evaluate the anatomic components of hyperfunctioning adenomas, incidentalomas, carcinoma. We will, for the adrenal cortex, then review carcinoma. For the medulla, we'll skip pheo or lightly tread on it and focus on neuroblastoma. Adrenal cortical carcinoma is the main disorder of the adrenal cortex that we see. It is uncommon, maybe 1 in 500 cancers. We have a pipeline to a Brazilian family with germline TP53 mutations. There's only about 25 new patients per year in the USA. They'll often present with virilization. Gavin Mackey, former fellow at the University of Michigan, who is now the nuclear medicine doctor in Norwood, Tasmania, did a survey of a couple institutions evaluating their experience with this tumor in both adults and in children. Those were his own institution, the University of Michigan, as well as St. Jude Children's Hospital, Maine Children's Hospital, and Barnes Children's Hospital in St. Louis. Here's an example. 5-year-old girl with clitoromegaly, breast development, elevated testosterone, elevated dihydrotestosterone, epiandrosterone, dehydroepiandrosterone, elevated at 684, about 4 times elevation of normal. The main tracer that we have used is fluorodeoxyglucose. Although this is rotating, you may be able to detect there is something above the left kidney. Let's look at it in cross section. Partially calcified large left upper quadrant mass with elevated uptake seen in the PET and on the fusion images. The uptake is variable, as we see from the next image. Less uptake, inferiorly large areas without uptake corresponding with low attenuation regions on CT, likely indicating necrotic debris. Thus, FDG is the principal radiotracer used to evaluate these. The conclusions from Gavin's paper was that FDG PET, this was actually pre-PET CT, is useful for the detection of adrenal cortical carcinomas. Caution should be used for lesions with low histological grade and in small pulmonary lesions. And that at that time, further evaluation is required to determine whether FDG PET may be useful for monitoring the response to chemotherapy. That was then. This is now. We've accumulated sufficient experience to be confident that FDG PET CT is useful for the monitoring of these patients with either recurrent or persistent disease. Now let's look at neuroblastoma. Neuroblastoma, the most common extracranial solid malignancy of children, about 650 new cases per year. Most of them present with stage 4 and widespread osseous metastatic disease. In general, the prognosis differs by stage. Earlier stage, much better, maybe surgically cured. Higher stage, prognosis may be 50% cure rate at best. There's a number of tracers that are available to evaluate neuroblastoma, and I here characterize them by their physiologic mechanisms. The most common is via HNET, the human norepinephrine transporter, where we'll talk briefly about MIBG, a couple of carbon-11 labeled agents, fluorodopamine and fluorometabenzoguanidine. 18-fluorodopa via the large amino acid transporter, FDG via the glucose transporter, somatostatin receptor localizers such as 68 gallium DOTA, then the XXX of your choice, and copper 64 tartrate. We also have an interest in antibody imaging of neuroblastoma that I'll touch on briefly. In the interest of time, we'll skip a few of these and concentrate on those that I haven't crossed out. The human norepinephrine transporter is what we are looking at when, for the most part, we look at neuroblastoma functional imaging. The the NET is responsible for the rapid uptake of the neurotransmitter norepinephrine into presynaptic nerve terminals, leading to the rapid termination of neurotransmission. MIBG, meta-iodobenzoguanidine, was synthesized by Don Whelan, an outstanding guy, an outstanding chemist at the University of Michigan in the late 1970s for imaging of adrenal medulla disorders and cardiac imaging. You know, it can be labeled with the iodine of your choice. Initially, that was I-131, and now more commonly I-123. I-123 MIBG was approved by the United States Food and Drug Administration in September 2008 for diagnostic imaging of both pheochromocytoma and neuroblastoma, and is commercially available 3 times per week. Don also synthesized a number of other norepinephrine transporter agents more commonly used for cardiac innervation studies. Those include metahydroxyephedrine with carbon 11 and carbon 11 epinephrine, a true radiotracer. That led then to this seminal paper in 1981 by first author Jim Sisson describing the results of this new study, I-131-MIBG, in about 10 patients with pheochromocytoma. Right here on our left is Jim Sisson, endocrinologist, nuclear medicine, and just about as fine as person as you could meet, did the seminal work on MIBG and functional imaging. Bram Shapiro, also an outstanding academic physician whose contribution to imaging of neuroblastoma in the early and mid-80s was seminal. And Dr. Bill Beyerwalz, who was the head of nuclear medicine at the University of Michigan for about 40 years and directed many of the studies in both thyroid and adrenal. This picture was actually taken at the home of Sandy McEwen, native New Zealander who ended up at Edmonton. Bram was a visiting guest. Bram Shapiro has an affection for dogs, and this is Sandy's dog. I think it was Sally. Okay. Why do I mention that? Well, the story I remember is that Sandy said this doggie suffered from intractable seizures, were not controllable, and died. Sandy asked then for a canopsy. And upon canopsy, the veterinary pathologist found out that this patient, this doggie, had a malignant pheochromocytoma. So here you have an expert on pheo holding a canine with pheo who belonged to another pheo expert. I maintain that I-123-MIBG is the single best functional imaging agent available for neuroblastoma. Anybody want to challenge that? Well, I'll walk it back. I-123-MIBG is a great functional imaging agent for neuroblastoma. Maybe there are others that will be as good or possibly even better, depending on how we define what we want. There have been a couple of papers published in the literature in the past couple of months that have to do with large-scale, multidisciplinary evaluations of I-123-MIBG in a couple of large cohorts of patients, one from the US and one from the European Association, European group. Among the co-authors we have present are Dr. Barsever and Dr. Parisi. The conclusions from the European study, which was a cross-validation of the US study, applying each continent's individual MIBG assessment, was that in 2 independent cohorts, they confirmed the prognostic value of the Syopen skeletal score, that is a semi-quantitative assessment of the extent of disease in bones, and found that in particular patients with an absolute Syopen score of greater than 3 after inductions have very poor outcomes, worse than horrible, and should be considered for an alternative therapeutic strategy. The same was found using a different, more simple quantitative, semi-quantitative evaluation of the extent of disease that also included a score for extraosseous soft tissue. And these authors, Yannick, Parisi, etc., showed that the prognostic significance of post-induction Curie scores has now been validated in an independent cohort of patients with a post-induction score of greater than 2. What that means is that if patient undergoes all the routine therapy of induction and still has a couple of spots of MIBG avidity, they are at particularly high risk for a dismal outcome. One thing that we have been involved in recently is investigation of quantitative SPECT-CT in a pediatric population. So the purpose of this particular effort was to devise a method to quantitate MIBG uptake using SUV, that is using SPECT-CT, and apply it to I-123 MIBG studies. It was to evaluate this particular Hermes vendor algorithm in 2 different SPECT-CT systems that we had. The opportunity arose because one SPECT-CT system was replaced by another in the middle of this project. It was retrospective for 1 year, included over 100 examinations and mid-50s patient, and from this we derive a actual number, an SUV of the MIBG concentration in all sorts of organs, whatever you want. What this particular graph shows is that the amount of MIBG quantitated in any particular set of tissues did not vary substantially between the 2 cameras. Thus, it is machine camera independent and could be applied then to whatever vendor you happen to have. This is one patient analyzed retrospectively. None of this information was used for clinical purposes, but it surprised us in that the amount of uptake was fairly well correlated with how the patient was doing. And once the uptake peaked, then with therapy, it gradually declined all the way to 0. Now this offers the opportunity not just for quantitation, but also for providing a common baseline from which we can review all the studies. Okay, if we knew what it was we were doing, it would not be called research, would it? Anybody, just yell out when you figure out who this was. Any ideas? Clock is ticking. First hint. Anybody? Second hint. That's right. Albert Einstein. It now has been 102 years since the theory of general relativity was published. I can remember when it first came out, there was a lot of controversy about it, but after he and I took a trip and figured out the curvature of light around the sun during an eclipse, then it seemed to be much more accepted. Don also synthesized a number of other cardiac sympathetic nervous systems. The one we have, nervous tracers, the one we have more experience with is carbon-11 hydroxyephedrine, carbon-11 epinephrine. These are great tracers, but because of the short half-life, then they are not commercially viable. I'll show you an image anyway. Here is a young lady who had recurrent neuroblastoma. This was a prolonged course. Here you can see in the right lower chest the MRI signal abnormality with dynamic imaging following the injection of carbon-11 labeled hydroxyephedrine. You see great uptake, which persists through 60 minutes. Compared to MIBG at 2 hours, you can see hardly anything, but at 24 hours, great MIBG uptake. We don't do early MIBG imaging in part because we don't see anything. This tracer and others, like with carbon-11 labels, could be imaged dynamically, and here in these cross-sectional images taken over a few minutes, you can see that even by 3 to 4 minutes, there's great uptake in this residual neoplasm. So in general, these positron-emitting tracers are less hydrophobic. The background clears more quickly. Carbon-11, we said, is not great, but fluorine-18, such as with fluorodeoxyglucose, could be commercialized, and it would be also quantitative. Candidates for distribution include one we're interested in, fluorodopamine, another compound that has been used in people we'll look at in a few moments, called metafluorobenzoguanidine. There's also been some reports of meta-iodofluorobenzoguanidine. The one I'd really like is fluorine-18 norepinephrine, the native compound virtually, and I-124 MIBG. We'll just look at a couple of these. This is Carol Pasek. He's the principal investigator of pheochromocytomas, particularly scintigraphic imaging, at the National Institutes of Health. And his literature data has shown that fluorodopamine is the single best functional imaging agent for pheochromocytoma. It was developed in the late 1980s by Goldstein and others, specifically for imaging the sympathetic innervation of the heart. Not widely available, in other words, not available outside of Bethesda, Maryland, in part because of the relatively low specific activity that one encounters. Keep in mind that we're talking not about the synthetic pathway of dopamine, but its ability to be taken up, concentrated, and stored in storage vesicles. So, make a long story short, this is great stuff. That it is at least as good as I-123, I-131 MIBG, but in certain patients, then metastases are better detected using dopamine, fluorodopamine. Here's a patient from one of his experiences. Tremendous uptake in a mediastinal mass, many small bone metastases, retroperitoneal lymph nodes, excretion through the kidney, solitary kidney. One kidney had already been excised. You also notice some similarity with MIBG biodistribution, salivary glands, and good uptake in the heart, liver. From another paper that Carol wrote, we see a comparison in a single patient of fluorodopamine, fluorodopa, fluorodeoxyglucose, and I-123 MIBG. In this case, the fluorodopa was not so great. Fluorodeoxyglucose showed some of the lesions. Most of the lesions were best seen by fluorodopamine. You might say it's not completely fair to mix technologies and tracers, as the MIBG is, in this case, assessed by planar images, whereas the PET, of course, is intrinsically tomographic. We are hoping or expecting to start studying fluorodopamine in neuroblastoma, expecting that it will be concentrated in sites of neuroblastoma and that it could lead to better patient care from better detection and quantitation of residual and persistent disease. This is made possible because of a collaborative effort between our St. Jude chemists and chemists at the University of Nebraska and University of Illinois at Chicago, who have developed a method of synthesis that produces the stuff of much higher specificity. Here is a notebook called FlowPet. It is this thick. This is what we call an IND, Investigation New Drug. This is the size of the application generated to put this stuff into people. It's gone through the FDA, it's gone through our local IRB, and we're hoping to begin studies relatively soon. MFBG, metafluorobenzoguanidine, has been published recently by Nita Pandit-Taskar from MSKCC, Memorial Sloan Kettering Cancer Center. She describes 5 patients with pheo, 5 patients with neuroblastoma. On your left are the MIBG anterior and posterior images. On the right are the anterior and posterior projection images from the same patient with neuroblastoma. In this case, you can see more sites of disease with the MFBG, and you can see them more clearly. This study is now, I think, in phase 2. There are many more patients being recruited, and it also looks promising. NITA's preliminary data shows that MFBG imaging is safe, has a favorable biodistribution and kinetics with good targeting of lesions. Keep in mind that this is about 1 to 2 hours after injection. And that PET imaging with MFBG allows for same-day imaging of neuroblastomas and PHEOs, highly promising for imaging of patients with neuroblastomas. And other work is being done. We're skipping fluorodopa, we're skipping fluorodeoxyglucose. Fluorodeoxyglucose's role in neuroblastoma imaging is well established. We have found that it's particularly useful for those patients whose studies are MIBG negative, or for patients with early stage disease in which it is likely to cause the least change in patient management. Another study that we're interested in involves a radiolabeled antibody. GD2 is a disialloganglioside found on most neuroblastoma cell surfaces, as well as some osteosarcomas and most melanomas. In a collaborative project with Boston Children's Hospital, we have done some in vivo studies looking at the biodistribution of a particular antibody called HU1418K322A, which is similar to the antibody CH1418, which is used in almost every patient with newly diagnosed neuroblastoma in the USA on COG's, Children's Oncology Group, protocols. Thus, we're trying to radiolabel this particular agent for human use. Dr. Snyder of our group has produced a couple of compounds. One of them is copper-64 labeled, and the other one is zirconium, which allows the opportunity to image for several days. Some in mouse work here. In skid-bearing mice, you see a great deal of uptake with the copper-64. Keep in mind that there is a negative control on the other side that you don't see very well. That's good, some specificity. Here's zirconium of the same type mouse. Again, good uptake at 48 hours, great retention at 7 days. Again, a negative control on the left of the mouse. So good sensitivity, we think good specificity. The purpose of this study then will be, one, to help eventually direct neuroblastoma antibody therapy, and also to evaluate GD2 status in other pediatric tumors, particularly osteosarcoma, in whom therapy, especially for refractory disease, is often unsuccessful. All right. So first, as far as GD2 PET, I'll just say we're having good results and hoping to take it to human studies in the next 6 months to year or so. Summarize, we've looked at a bunch of tracers for tumors of the adrenal gland, both cortex and medulla. There is a host of tumors types, tumor imaging agents available, including those with somatostatin receptors and what we expect to be an outstanding imaging agent, copper-labeled 64 sartate. And what about the future? Where do we go from here? All right. Make nuclear medicine great again. Well, I'd propose that we're already great, and we want to keep going. I need some help with this. Again, a quote. I say nothing original. Difficult to see, always in motion is the future. There's a famous philosopher. Sorry? Okay. And here's a question for you. What is Yoda's last name? Well, just keep in mind the null set is a subset of any set. So he has no last name. All right, one more. I never think of the future, it comes soon enough. All right. I have had the pleasure of seeing your country, places that not many people get to go to. Here I was at Kangaroo Island, and I ran into these two blokes, these nuclear medicine physicians, Dr. Kreuss from Innsbruck, Austria, my good friend Ian Kirkwood from Adelaide, who are very attractive to kangaroos that are hungry. We did a little more touring, and this koala way up in this eucalyptus tree stared us down for several minutes before allowing us to go on. I don't think we have time for questions, which is just fine. I've already composed some answers. Among the answers are, it's too soon to tell. Just why do you want to know? That's true, but on the other hand, I'll have to check and get back with you. It depends. Or I can't give specific medical advice. And I think that is it.
Thank you, Barry. I'd like to introduce our last speaker, Dr. David Patterson from Royal Brisbane Women's Hospital. He's a nuclear medicine physician and endocrinologist, and he will be speaking on F-DOPA imaging in hypoglycemia of infancy. Thanks for bearing with us, just running just a little over time.
Okay, great. Okay, thank you. Thanks for the opportunity to speak here today. So I'll be talking about F-DOPA imaging of congenital hyperinsulinism, and essentially give a bit of an overview of the genetic background to this condition, a little bit about the imaging principles, synthesis and imaging protocol that we use with fluorodopa, go over the patterns of uptake and provide some case examples. So really, congenital hyperinsulinism, it's a heterogeneous condition due to dysregulated and inappropriate insulin secretion, and it leads to severe hypoglycemia. It can be either transient or persistent, and there's a variety of forms, including focal, diffuse and atypical forms, and distinction or identification of focal forms is important for potential curative surgery. Genetic testing performs or is required for is indicated for otherwise unexplained hyperinsulinemic hypoglycemia, and particularly in the group that's unresponsive to diazoxide, and is generally informative in influencing the subsequent diagnostic workup in about half of cases. So looking at the genetics that underpins congenital hyperinsulinism, there's really divided into channelopathies, which are genetic defects that encode two of the subunits of the ATP-sensitive potassium channel, which subsequently leads to closure, alteration in intracellular calcium and insulin secretion. And these genetic abnormalities are typically associated with diazoxide unresponsive cases because diazoxide acts as a potassium channel opener. The other major group is that of what's characterised as the metabolopathies, and they're as listed there. Mouse isn't working. So localisation of potential focal lesions are recommended if surgery is considered, and that's particularly cases that are medically unresponsive, and especially if genetic testing favours a focal lesion. And that's with these two channelopathies, which are typically associated with focal disease. So this is a proposed genetic and imaging workup algorithm, whereby initially the genetic testing is performed. If there's either ABCC8 or KCNJ11 mutations, the particular inheritance of this, so particularly if it's paternal heterozygous mutation, that's particularly associated with focal hyperinsulinism and prompts an F-DOPA PET. If it's another form of mutation, so either maternal heterozygote or homozygous, then it's typically associated with diffuse disease, and the F-DOPA PET isn't initially indicated. But if the parent of origin is not identified, or if there's a negative gene mutation, but there's persistent need for significant medication requirements, or it's unresponsive, that's another indication for F-DOPA PET. And the management is really influenced. If it's either diffuse or atypical and then it persists to be unstable on medical treatment, often the procedure, when required, is subtotal pancreatectomy. But if there's localisation of focal source, then that can lead to a focal lesionectomy with greater preservation of residual pancreatic function. Because the main risk long term is the development of insulin requiring diabetes. So in terms of the imaging principles, it's based around the co-secretion of dopamine and insulin in pancreatic beta cells, and there's an autocrine inhibitory pathway is hypothesised for the secretion of the dopamine. And then fluorodopa, which is an L-dopa analogue, is taken up via the LAT2 mechanism and then decarboxylated to dopamine. And in terms of the physiologic distribution, we find that it's excreted renally, so you can see uptake in kidneys, ureter and bladder, and also excreted via the gallbladder into the biliary tract and bowel, and also seen in liver, heart and basal ganglia. In terms of production, I won't go through this in much detail because of time, but it used to be made via electrophilic fluorination, but more recently the approach, and certainly at our centre for the last few years, is the nucleophilic fluorination process, which is easier to synthesise. It's using an automated synthesis process, higher yield, and there's less hazardous tin intermediate, so there's no HPLC required. In terms of the imaging protocol that we use, look, it requires careful coordination with the referring team. It's preferable, if possible, although there is controversy about the need for this, to withhold hypoglycemic medication for 48 hours prior. The paediatric patients are imaged under general anaesthetic, and it's generally a 60-minute list mode acquisition over the abdomen, which then can be, have 6 10-minute reconstructions, so that you can actually see. That's useful to assess for biliary excretion and clearance, which can lead to be associated with false positives. So the patterns of uptake: generalised increased uptake throughout the pancreas, with relatively higher uptake in the head and uncinate process. That's characteristic of diffuse pattern. With the focal form, that's solitary focal uptake within the pancreas. And there's also atypical forms, including recently described giant focal form, where the extent can be underestimated by fluorodopa PET, and also you can have ectopic lesions as well. Pitfalls, so false positives, can be due to physiologic uptake in the pancreatic head, like we can see in other imaging such as dotatate imaging, and also because of physiologic biliary excretion into the adjacent duodenum that can be misinterpreted as focal pancreatic lesions. And false negatives are those with lesions in the tail of pancreas near the kidney or adjacent to the duodenum. The sensitivity, there's some heterogeneity in this meta-analysis, but overall the pooled sensitivity is high. It's nearly 90%, and it has high specificity of about 80%. So there's a growing amount of literature supporting the role of this, and it really is a critical investigation in the evaluation of congenital hyperinsulinism. Can either be done as qualitative analysis or quantitative, and this was a recent paper just published earlier this year where they did a ROC analysis of 53 cases, and they came up with a SUV max ratio of 1.44 that was very accurate, and this is getting a volume of interest over the involved region of the pancreas and then the least avid non-involved region of the pancreas, and you can use the highest ratio from any of the time points to determine this. It had very high inter-observer reliability and quite very high accuracy in this study, with exceptional sensitivity and specificity. And so here's a couple of cases. This is a patient, young 3-month-old male, and here you can clearly see this focal uptake in the head and uncinate process of the pancreas, with minimal uptake elsewhere, and using that SUV ratio of 4.1, which is fitting with a focal lesion. This is another case of a 6-month-old male who had more diffuse uptake that you can appreciate from the MIP. This is in a coronal view, and if you do the ratio from the head to the tail, it's a ratio of only 1.3, and it really fits with a diffuse process. This is a third case that's just showing this was actually ultimately an atypical form, and some of the challenges associated with the interpretation, where there was this quite large focal area in the body and tail of the pancreas. There was also another region of focal uptake that you could see in the uncinate process, and ultimately this patient went to have it was felt to be most consistent with the diffuse form. They went to actually have subtotal pancreatectomy but had persistent hypoglycemia. And on the repeat imaging that was done, it showed that they actually hadn't resected that large region, they only partially resected that. And so they went back to further resection and have cured the hypoglycemia. This is just a summary of some of the experience from the Royal Brisbane of 20 cases that have been performed, and really showing that in the paternal potassium channelopathies, that it shows that although that's where you find the focal cases, you do also find that there can be the diffuse form as well in these cases. And there is quite a large variety of pathologies identified. This is just, I guess, looking to the future, and something that's been hypothesised is using other agents such as GLP-1 receptor imaging. And in fact, in this patient that I mentioned earlier who had this uptake in the head uncinate process, because it's significant management implication to resect a lesion at that site, and concern about potential false positives, the referrers actually proceeded with doing a GLP-1 PET as well, which showed concordant uptake and confirmed the source of, and this was confirmed to be a focal lesion. So in summary, really there's an enlarging evidence base supporting the role of fluorodopa PET for congenital hyperinsulinism. It really should be, localisation with fluorodopa should be performed if considering surgery, particularly in medically unresponsive cases, and especially if the genetics favours a focal lesion. There are these different forms, and the interpretation can be either a qualitative or quantitative approach. One of the key elements is, the need for multidisciplinary care in specialised centres, because it's quite a rare condition, and there's some challenges in the interpretation. And future research could be performed into GLP-1 imaging in this disease, as the pathogenesis is actually felt to be associated with the GLP-1 receptor signalling. So thank you.